I'm very happy to be here, and I'm very happy to introduce the next speaker, who happens to be my colleague at the Aga Khan University. She is Dr. Sitna Mwanzi, as you all know, is also the chair of Kenya Society of Hematology and Oncology. She's a consultant medical oncologist, and her experience and her presence is very well known in Kenya. Her personal interests are in breast cancer, prostate cancer, cervical cancers, and chronic myeloid leukemia. She is passionate about increasing healthcare worker awareness and general public awareness about the cancer role of screening, early diagnosis, and treatment of cancer. She also works very closely with National Control Program in Kenya, National Cancer Control Program in Kenya, and the NCI strategies for prevention and screening of cancer. She has also been involved in the development of national guidelines of Kenyan guidelines for cancer treatment, and has also been part of proudly the National Comprehensive Cancer Network in the US for producing the harmonization guidelines. I'm very happy that she's talking about one of the fundamental topics. Kidney, as you know, is affected not only primarily by cancer itself, but it deals with cancer in so many ways. For example, Dr. Baga mentioned one of the drugs toxicity profile, and the first speaker, Dr. Walla, spoke about AKI in cancer. So the relationship between cancer and kidney is very, very close. As you would see, almost all cytotoxic agents are handled by kidney. And the newer agents Dr. Baga talked about have a very different toxicity profile. Kidney is affected by the cancer primarily, which Dr. Sitna is going to talk about, but very rarely kidney is also site of metastasis. So a lot of things that associate kidney and cancer. But let's welcome Dr. Sitna to speak about the renal cell carcinoma, the primary renal cell carcinoma. And let's hear what she has to say. Welcome, Dr. Sitna.
I'm thanking Professor Asim for the kind introduction. As he has said, I'm Dr. Sitna, and I work with him at the Aga Khan University in the oncology department. And I'd like to thank the KRA organizers for allowing me to talk about renal cell carcinoma. I have no disclosures for this presentation. Just a brief overview of what I'm going to talk about. I'm going to talk about the epidemiology of RCC, a bit about the pathophysiology and how it's related to the current treatments that we have, the clinical presentation, and the diagnostics for RCC. From the West, RCC is ranked as the third most common cancer in adult malignancies. And as you can see from the Kenyan data, it's not that common. It's actually accounts for about 0.8% of all the cancers. And in 2018, we had about 418 cases and 236 deaths. There is a male predominance of almost 2-to-1 ratio. And this cancer in the West is diagnosed most commonly after the age of 60. In the last 2 decades, we've seen an increased incidence in the diagnosis of RCC, and this is mainly due to the increased use of ultrasound and CT scan. So many patients are diagnosed incidentally when they're imaged for other reasons and found to have a renal mass, which is then now investigated and found to be RCC. On the contrast to that, the mortality hasn't changed because a lot of these early tumors are found on CT scan, and there's been a lot of treatments that have come up, including the immune checkpoint inhibitors that Dr. Hussein Baga has very well illustrated in his presentation today. Our local experience at Aga Khan, I just looked at data for 2 years, 2019 and 2020. As you can see, it is not very common. We had about 18 cases, and again, we had the same ratio, about 12 males and 6 female patients, and the age range is 28 to 84 years. So our youngest patient was a 28-year-old lady, and our oldest patient was 84. But our mean age, as you can see, is much lower than what is quoted in the West at 54 years. And the commonest pathology that we see here is the clear cell RCC. And the thing about incidental cancers, I came across at least 3 patients who were incidentally diagnosed with RCC when they were being evaluated for other conditions. Recently, we had a 45-year-old who was found with advanced gastric cancer, and during evaluation was found to have a left renal mass. Another patient, 67-year-old with thyroid cancers, incidentally found to have RCC when staging scans were being done. And most recently, a patient treated for RCC who had nephrectomy 16 years ago and now has a recurrence of his clear cell carcinoma, which was diagnosed on biopsy. So you can see that this incidental finding of RCC is not just something that is reported in the West, it's also something that we are seeing locally. So in terms of risk factors, I think I've highlighted renal risk factors in the sense that patients with end-stage renal disease, patients with polycystic kidneys, patients who are post-kidney transplant, and patients who are on long-term dialysis have a higher risk of RCC, and mainly it's because they tend to form renal cysts, and these renal cysts can progress into renal cell carcinoma. Other risk factors, we talked about the male gender, obesity, hypertension, kidney stones, and occupational exposure to chemicals. We often talk about genetic mutations in RCC, but they account for only 2 to 3% of RCCs. And the patients who have genetic mutations tend to have multiple bilateral disease or have multiple lesions in one kidney, as opposed to those who have sporadic disease. A little bit about the genetic mutations. The most common genetic mutation identified is the von Hippel-Lindau gene, which mutation, which is on chromosome 3, and it's more often associated with the clear cell histology. I think what is important here is that this mutation is not only found in the germline, it's actually quite common in sporadic RCC. So you find that even without a germline genetic mutation, a lot of patients with RCC will have a defect in the VHL gene. And then there are all the others that are listed here. One of the things that's not listed here is the tuberous sclerosis, which is actually associated with RCC, but the exact mechanism is not very clear. In terms of pathology, RCC arises from the renal epithelium, mainly of the PCT, and this accounts for 95% of all adult kidney tumors. When you talk about pediatrics, it's completely different, where you have mostly the Wilms tumor. Apart from RCC, you can have other histologies that we need to keep in mind, such as lymphoma, sarcoma, and transitional cell tumors that may arise from the kidney. Clear cell carcinoma, I think this will be important later when I'm talking about the treatments, but clear cell accounts for majority of all the RCCs that we see, and the other types such as the chromophobe and medullary are actually less common. In terms of pathophysiology, and the reason I'm putting this here is that it has a lot of relevance to the treatment of RCC. Some of these are not new to nephrologists because a lot of the agents that we use here will be used by nephrologists. All nephrologists will know about the mTOR pathway. And now you already know about the immune checkpoint pathway that Hussein has very eloquently described. But one of the other pathways is the hypoxia indicible factor pathway, which I will briefly go through. So the reason why the VHL gene product is important is in the presence of a normally functioning VHL, it acts as a tumor suppressor gene. And what it does, it prevents the activation of the hypoxia indicible factor A. And if you have normal oxygen tension in the kidney, you have hydroxylation of the HIF-A, and then it is degraded. So you don't have activation of the proteins that are on the left side. But in the absence of a normally functioning VHL, you lose this tumor suppression factor. And what happens, you have the dimerization of HIF-A to HIF-B, which causes increase in transcription of these factors such as erythropoietin, vascular endothelial growth factor, platelet-derived growth factor, transforming growth factor, and the others that are, as you can see here. And a lot of, when you have overexpression of these factors, you now have the potential for abnormalities happening and proliferation of cancer cells. And this is also important in terms of the therapies, as I will share very briefly. The mTOR pathway, which all nephrologists are aware of, if you have binding of growth factors such as the vascular endothelial growth factor or the platelet-derived growth factors and other growth factors, you have activation of the PI3K pathway, which downstream will lead to activation of mTOR. And mTOR will lead to increased transcription of HIF-A, which we've already talked about, will increase your erythropoietin and VEGF, which means that cells will continue to proliferate and survive longer, and leading to growth of cells and potential of metastasis of these tumors. I won't go in detail about the immune checkpoint pathway because I think Dr. Berger talked about it, but it's important to know that RCCs are associated with immune response. Even before the immune checkpoint pathway, renal cell carcinomas was treated with interferons and interleukins because they are known to be very, very closely linked to the immune system. In terms of the clinical presentation, in medical school, we are all told about the triad of flank pain, hematuria, and abdominal mass, but we know that this only is only seen in about 10% of all the patients that we see. And when you have the triad, it means that a patient has advanced disease. The most common presentation is actually hematuria, after which a patient is then evaluated. And then because of release of cytokines, we have all the other symptoms such as weight loss, fever, night sweats, hypertension, hypercalcemia, and malaise. And what I found interesting is that in a certain percentage of male patients, if you find a left-sided varicocele, you should be thinking about RCC because of the involvement of the left gonadal vein. Of the cytokines, like you have a lot of paraneoplastic syndromes that patients present with. They can also present with neurological symptoms. They can present of symptoms of hypercalcemia, and also they can present with erythrocytosis because of increase in erythropoietin. In terms of diagnosis, I think the full blood count is very important. If you find erythrocytosis, it is a paraneoplastic feature of RCC, but patients, because of hematuria, can also present with anemia. And the full blood count becomes important when we are prognosticating for our patients with metastatic disease, where the platelet count and the neutrophil count are very important in risk stratifying our patients. Of course, nephrologists will look out for hypercalcemia, and then patients have renal dysfunction, and the renal dysfunction can be because of the tumor itself, if it is occupying a large part of the kidney, or if it's causing obstruction, and also if it's causing hypercalcemia, which can lead to renal dysfunction. And then you can have deranged LFT that is not a function of metastasis, but is actually a paraneoplastic syndrome. And one of the important things to look out for is hematuria with clots in your urinalysis, which is a function of bleeding from the upper pole of the kidney, and very important to request for urine for cytology. The most common image that is done is an ultrasonography, but the gold standard for diagnosing and staging these patients is a CT scan with contrast. In the event that a patient cannot get contrast because of renal dysfunction, then an MRI of the abdomen can be used in its place. And an MRI is actually a little bit better in determining the local extent of the disease and if there are lymph nodes involved. And now, as you know, we have PET-CT scan available in our hospital and in the country, but it's not actually recommended for the initial staging for renal cell carcinoma. And then if patients have other symptoms, for example, neurological symptoms, we know that RCC can metastasize to the brain very often. So an MRI of the brain is something that we should also think about if a patient has any symptoms. Then I think a very important question that we often ask ourselves, should we do a biopsy for this patient? I think a biopsy is important in patients who have smaller lesions where we are thinking about limited treatments. But if a patient has limited disease and we are going to go for a nephrectomy, then a biopsy can be omitted. In the metastatic setting, then a biopsy is very important because we need to differentiate whether a tumor is the clear cell variant or it's a non-clear cell variant, and we'll talk about therapies in a few minutes. So I found this illustration very good in terms of talking about the staging of renal cell and actually linking it to the survival you can see that early stage 1 tumors are less than 7 centimeters and are confined to the kidney. And the 5-year survival with nephrectomy alone is about 95%, which is very good, as opposed to stage 4 disease where the tumor is beyond the Gerota's fascia, or you have one or more lymph nodes involved. And you can see that in these patients, the 5-year survival is 20%. So stage 1 and 2 are more of the early tumors where your survival is over 80%. But as you go to your stage 3 and stage 4 disease, then you can see that your survival is actually approaching 20%. I think one of the important things about stage 3 tumors is that when we're evaluating these patients, if you have adrenal gland involvement, or you have inferior vena cava or renal vein involvement, then those are areas that the surgeon, mainly the urologist, will have to make sure that they take care of during the surgery. So just moving to the treatment. So if we have localized disease and the size is less than 4 centimeters, then there are actually options for doing less aggressive surgery, whereas for larger tumors, which are central, or they're involving the lymph nodes or involving the adrenal gland or the vessels, then a patient is considered for radical nephrectomy. But if you have smaller tumors or a patient has solitary kidney, or they already have pre-existing chronic kidney disease, then there should be some consideration for partial nephrectomies. And then if you have patients who have other medical conditions, they're not good surgical candidates, and they have smaller tumors, then there is possibility of doing ablative treatments such as radiofrequency ablation and cryoablation. What I would say is that most of our patients will more often than not go for nephrectomy. So if a patient goes for nephrectomy, then it means that they are left with one kidney. So the follow-up for this patient involves nephrologists, in the sense that this patient already have some form of chronic kidney disease, and they will need follow-up from a nephrologist point of view, in the sense of making sure we don't give them nephrotoxic treatments, making sure we don't give them iodinated contrast, and also making sure that if they have a recurrence, we are able to take care of that. So I think an important question for oncologists, at least, is if a patient has had surgery, do you need to give them any other treatments? And adjuvant treatment, which is treatment after surgery, is considered in high-risk patients. And high-risk patients are patients with high-grade disease or have stage 3 disease, or have a clear cell histology, which is considered to be more aggressive. There are about 3 clinical trials that were done, but only one trial showed benefit in disease-free survival, but not overall survival, by using a vascular endothelial growth factor tyrosine kinase inhibitor, sunitinib, for 1 year. So I think different guidelines differ. In Europe, it's not considered a standard treatment, but it's considered as a possible treatment in America. There's no role for radiotherapy after nephrectomy. And I think one of the important things to know is that 20 to 30% of patients who have nephrectomy for early disease will actually have a recurrence after surgery within 3 years. I think in the metastatic disease, we still consider surgery in patients with good performance status, especially if they have low volume metastatic disease. And one of the other things that people are thinking about, if, for example, they have one area of the liver that's involved, can we go and remove that metastasis and just make sure that there is no disease left behind? But you can imagine that this will be the minority of patients. Patients with brain and bone metastasis should be considered for radiotherapy. And patients with extensive metastatic disease will be evaluated for either tyrosine kinase inhibitors or immune checkpoint inhibitors, which Dr. Berger has talked about. The reason we do not use your standard chemotherapy for patients with RCC is because they are relatively chemoresistant, and this is because of high expression of B glycoprotein, which basically makes the tumor resistant to most therapeutic agents. So the reason I spent a bit of time talking about the pathology is because it has a direct correlation to all the treatments that we have. On the one side, we have the vascular endothelial growth factor tyrosine kinase inhibitors, and you can see that there's a long list of drugs. And the importance of this is that when you have overexpression of vascular endothelial growth factor, we can target it either in the intracellular domain using a small tyrosine kinase inhibitors. Most commonly, we use sunitinib and pazopanib. And on the extracellular surface, you can use drugs like bevacizumab. So you can see that in the last maybe 10 to 20 years, there's been like an increase in the number of drugs that we can use. On the other side, this is what Dr. Baga was talking about, targeting the program death ligand and protein using immunotherapy, and also using the ipilimumab, which is the CTL4 inhibitor. And then the mTOR pathway, which is familiar to all of us, is targeted by everolimus and temsirolimus. So these are the main drugs that we use. And I think I won't go through this because Dr. Baga talked about this. And if you look at how these treatments have emerged over the years, is that up to 2019,
everyone was
using the tyrosine kinase.
I thought you had already gone, so.
Sorry.
I thought
Can you please mute your mic?
you had already gone.
It's not speaking.
Sorry, Professor Kayema.
Professor Kaima, could you please mute your mic?
Okay, so as I was saying, there's been a lot of advances in treatment. So before the 1990s, we were using a lot of interferon and interleukin for treatment of metastatic renal cell carcinoma. But from around 2005, when the tyrosine kinase inhibitors were discovered, then these have been the mainstay of treatment. But the change that happened last year is that there's a lot of data coming out now that the immunotherapies do a little bit better than the tyrosine kinase inhibitors, especially in the patients who have a poor risk clear cell renal cell carcinoma. So you can see that there's a lot of growth in terms of the drugs that we're using, which means that we have better outcomes and reduce mortality from renal cell carcinoma. And just to illustrate some of the risk stratification that we use, which is why I was bringing out your hemoglobin, your calcium, neutrophil count, and platelet count, because these are important in terms of giving us a risk score and will help us to determine the type of treatment that patients will get. Because this is not an oncology lecture, but a nephrology lecture, I've just summarized how us as oncologists will decide which treatment to use. And basically, we use a lot of the risk stratification. But you can see that the immune checkpoint inhibitors that Dr. Baga talked about are now first-line treatments. And you can see that the tyrosine kinase inhibitors are now more of second-line treatments. And then Dr. Were asked about availability of these drugs. They are available, but some of the toxicities, including financial toxicities, may preclude us from using a lot of these drugs. And this chart is mainly for clear cell histology, because that's where all the data has been. And in the non-clear cell RCC, we're using a lot of the TKIs. So in terms of our local experience at Aga Khan, our main treatment modality for early tumors is nephrectomy. For certain patients, we talk about adjuvant treatments for high-risk patients. And the commonest tyrosine kinase inhibitor, which targets the VEGF, the ones that we use commonly are pazopanib and sunitinib. And like I said, immunotherapy is available and we use it for some patients, but the cost is prohibitive. One dose of pembrolizumab is about $8,000, which is about 800,000 Kenya shillings. And this treatment has to be given every 3 weeks for a total of 35 cycles. So you can imagine that the number of people who will be able to afford this will be minimal. The other thing to think about is the toxicity. Dr. Baga has talked about the immune-related adverse events associated with immune checkpoint inhibitors. But I think importantly for the tyrosine kinase inhibitors that we use for renal cell, they can actually cause chronic kidney disease through many mechanisms. Some of them include increasing vascular tone, decreasing pressure in the kidney, leading to renal dysfunction. A lot of these drugs cause hypertension, they cause proteinuria, they cause arterial thrombosis. And then if a patient bleeds, potentially they can have issues. The other side effect that they have that Dr. Baga mentioned is colitis. So diarrhea is also something to be worried about, and this can lead to chronic kidney disease.
How are you doing?
So in as much as we're using them as a treatment, they can also have adverse effects on the remaining kidney or on the renal function for the patient. So in summary, although this is an uncommon cancer, it's becoming a very important cancer for us, especially because we're using a lot more diagnostics. We're likely to find more cancers incidentally. And because we have more treatments available, we are likely to improve our outcomes. And we need to be careful about potential renal dysfunction from the tumor itself, or some of these treatments that we're using for renal cell carcinoma. Thank you, and happy to answer any questions.
There is one where there is the risk of seeding after renal biopsy. What do you comment on that?
I think that's an important question, and that's why, yeah, thanks, Dr. I think that's an important question, and that is why I said that a biopsy is only, for example, if you have metastatic disease, or if you have smaller tumors where you're going to be doing less aggressive surgery. But more often than not, just based on the radiological imaging, patients will go for nephrectomy without confirmatory biopsy because of that small but important risk of.
The other question is, how sensitive is the test for urine cytology in diagnosis of renal cell carcinoma and differentiation also? Urine cytology.
That's a good question also. I think the urine cytology is, it's not going to be your diagnostic tool. You're just going to use it for patients with hematuria to see if they have malignant cells. But I think the imaging is what will be the important thing. So the CT scan of the abdomen with iodinated contrast is the gold standard. And there are some radiological features that radiologists will tell you that this is highly suspicious for renal cell carcinoma. And that is kind of more sensitive than using urine cytology.
We have the renal cell carcinoma being an important malignancy following kidney transplantation. What protocol should we put in place in the post-transplant clinic for looking for renal cell carcinoma? The regularity of the ultrasounds, the screening and all that, what do you have any recommendation?
So thank you. That's a very good question. And I kind of mentioned that post-transplant or patients with end-stage renal disease or on long-term dialysis are actually at increased risk of RCC. And I think the recommendation is repeating your ultrasound every 3 to 6 months. And patients who have renal cysts, like polycystic kidney, also have more risk for this. So doing your ultrasound every 3 to 6 months. And if there are abnormalities that are seen, then asking for an enhanced CT scan. And if you can't do an enhanced CT scan, then the best test to do is actually an MRI of the abdomen.
Yes, what do you think we should do? Should we use drugs before treatment, or should we go for it?
Yeah, I think that's a good question. And in contrast to other tumors such as breast cancer, where we used chemotherapy before, there's actually been no benefit of giving any systemic treatment prior to the surgery. So in terms of like using these tyrosine kinase inhibitors to reduce the disease for you to do good surgery, there's actually no benefit in terms of improving the outcome for the patient. And I think that's an important question because during my preparation for this presentation, they actually say that if there's an IVC thrombus, then thrombectomy actually improves the survival as opposed to leaving the tumor thrombus behind. Of course, this will be technically challenging and will need assistance from vascular surgeons because it's not something that will be easy to do.